Thank you, Shripriya. Good evening to Dr. Sunil Kumar. It's a pride and privilege to introduce him to our batch. He is the additional director for the Trivandrum Institute of Palliative Sciences, which is also a WHO collaborating center for training and policy on access to pain relief. Pain relief is one of the important things which we try to cater to all patients of India. Dr. Sunil Kumar has obtained his diploma in palliative medicine both from India and a master's degree from Cardiff in palliative medicine too. He has a wide, long years of experience in palliative medicine, and he heads not one but three services: the clinical services, academics, and the research team of Pallium India. So, with that, I hand over to Dr. Sunil Kumar to take us through this session.
Sir, you are not audible. Sorry. Sunil sir, you are not audible.
Okay. I don't know. I didn't do anything. So, okay. So let me share my presentation. So is it visible?
Yes, sir. Perfect. We are good to go.
Today everything is behaving very strangely. I don't know what happened.
Some days are like that only, sir. Maybe because of month end pressure.
They're all being naughty, that's all. So, managing naughty things. Fine, we can.
Okay. Thank you everybody, and sorry for the technical problems. So we will move. So this is what we are planning to cover in the session. Um, what are the step 3 opioids available in India? And we may not be able to cover all the step 3 opioids because I believe we have a separate session on methadone. And how opioids acts. We know that every drug has a mechanism of action. So how opioids will act, and most importantly, when we practice, we will have many doubts regarding the use of opioids. So we will see what are those practical problems and um, side effects of opioids is something which we need to understand. So we'll go through that. And this is, you may think this is least important, but I would say this is most important, one of the most important aspects of opioids. Not only opioids, but also for any medicines, because we know that there are many medications available, and if you prescribe costly medications, the chance of a poor patient taking that medication would be very low, and they may come to you again with um, complaining that my symptom or problem is not reduced. And at that time, we would simply increase the dose of medication or change over to another medication. But why that symptom has not decreased? Probably because they didn't had money to buy the medication that you have prescribed. So we need to understand the prices of different opioids because that's also very tricky. So all of you know that this is the WHO analgesic ladder. And from second step onwards, we have opioids. And in the second step, we have opioids for mild to moderate pain. Whereas in the third step, we have opioids for moderate to severe pain. So can anybody tell me what are the opioids available in India in the third step of analgesic ladder? You can either unmute or you can just type in the chat. Yeah, I can see morphine. Yes, that's right. Any other medication available in the third uh, opioid in the third step of analgesic ladder? So actually, tramadol is actually coming in the second step of analgesic ladder. Tramadol is an opioid to treat mild to moderate pain. Okay, so I can see morphine, fentanyl, and methadone. Okay, so those are the three medications available for treating severe pain in India. Okay, tramadol is a opioid in second step. So can anybody tell me what is the problem or what is the issue this patient is facing? Look at this picture and tell me what he is suffering from. Jaw pain, pain in oral cavity, facial pain, joint pain. Yeah, that's correct. So this patient is suffering from very severe pain. You can see his facial expression. So it's a patient with carcinoma of the larynx, and his main problem at this moment is uh, very severe pain. You can see the worst imaginable pain, 10 by 10. And he is describing it as a sharp pain without any radiation. And this pain was there for the last 2 weeks, and because of this, he is also unable to sleep. So you can think how severe this pain would be. And suppose this patient comes to you, how are you going to manage this patient? What what medication are you going to use for this patient? Anybody? You can unmute and speak. Pain and sleep medication. Okay. What I'm asking, what pain medication are you going to use for this patient? I can see in message first we will try non-opioids. Opioids. Okay. Step 3 ladder. Yes. Can you name a specific medication that you are going to use for this patient? Morphine with analgesic. Yeah, that's right. So why you are going? Why you are using morphine for this patient? This patient has a pain score of 10 by 10. 10 by 10 means the pain. It's a worst imaginable pain. So the medications from the WHO analgesic ladder should be selected according to the severity of the pain. So the first step of analgesic ladder is used when the patient's pain is very mild. And second step is used for pain of moderate severity. And third step is used to treat when pain is severe. So 0 to 3, you can consider it as mild. 4, 5, 6, you can consider moderate pain. And 7 and beyond, it is severe pain. So in this patient, we have to use step 3 analgesic ladder. And in the step 3 analgesic ladder, we know that the first medication is opioids for moderate to severe pain. So out of this, the gold standard for treating acute severe pain is morphine around the globe. So there are many types of formulations available. It could be um, either orally available morphine or it can be an injectable morphine. Considering this patient's very severe pain, it's our duty to relieve it as early as possible. So we can give injectable morphine and relieve this pain. So how are you going to uh, give injectable morphine to this patient? What would be the dose? You can see this patient after 30, 40 minutes. He's smiling at us. So this is only possible because of intravenous morphine titration. So how do you do an intravenous morphine titration? So this is how you need to give morphine. Injection morphine 1.5 milligram at 10 minutes interval. So injection morphine 1.5 milligram intravenously every 10 minutes. Do you expect any side effect immediately by administering morphine? Anybody? Are you expecting any side effects immediately? Dr. Govinder says needs hospitalization. Um, okay, I can see there are various response sedation, no, not immediately. Okay, so one of the side effects when you administer morphine for an opioid naive patient would be nausea and vomiting. So you have to give an antiemetic. So what antiemetics would you use? We give injection metoclopramide 10 milligram IV followed by the first dose of injection morphine to avoid nausea and vomiting. Okay. And what is the endpoint or when will you stop intravenous morphine titration? Either the patient should have satisfactory pain relief or the patient should be drowsy, whichever be the first. So some patients may not have satisfactory pain relief, but they becomes drowsy first. So in that case, you have to stop the plan. So this is how you do an injection morphine trial. So you can see the time, pulse rate, respiratory rate, blood pressure, what is the pain score of the patient, is the patient drowsy or not? What is the dose of injection morphine you are giving? So suppose this patient came to us by 10 o'clock in the morning. You record all the vitals and you see that his pain score is 10 and patient is not drowsy at that time. So you will first give injection metoclopramide and then injection morphine 1.5 milligram. You will wait for 10 minutes. Then again at 10:10, you will again assess the vitals. You will ask the pain score. Now it's 7 and he is not drowsy. So you will give another 1.5. And you can see at 10:30 when you assess a pain score, the patient's pain has come down to 1. And that means patient has very good pain relief. So that's an indication to stop morphine trial. So we used a total 4.5 milligram of morphine, injectable morphine, IV morphine for this patient to get pain relief. So I would also like to say that this is not an inpatient uh, procedure. Actually, you can do it on an outpatient basis. Okay, so we do 1 or 2 IV morphine trial every day in our outpatient setting. So you want to send this patient home. So how are you going to convert this injectable or IV morphine to oral morphine? What would be the equivalent dose? Please type your answers. What would be the dose of oral morphine you will start? Yeah, we have to change to oral dose. That's what we want to do. But 4.5, yeah, I can see Dr. Amelia says 10 milligram. 4 hours is starting from 0.25 gram. Shift to oral, yes. What is the dose of oral morphine that you are going to start with in this patient? You have given an IV morphine trial and you found out that 4.5 milligram is enough for this patient. Okay. So can somebody unmute and tell me how did you came to 10 milligram orally? Okay. So this is the scenario, and you can see this is an article from 2000, where our chairman and his colleagues conducted this study, intravenous morphine for emergency treatment of cancer pain. And this was published in Palliative Medicine. And they found out that an approximate 1:1 ratio, that is intravenous is to oral, is a good starting dose, 1:1. That means whatever be the dose the patient has taken intravenously, that dose itself can be given orally, which will give good pain relief. So our patient received 4.5 milligram of IV morphine. So you can give 4.5 milligram of oral morphine, but um, 4.5 milligram of oral morphine is not available. So you can start with 5 milligram, as we have 10 milligram tablets, which you can break into two and start with 5 milligram. 5 milligram. And what is the duration of action of morphine? It is 4 hours. So you have to administer morphine every 4 hours. Okay. So this is how you give morphine to the patient. So you can see, so instead of when the patient wakes up, make it 6 a.m., then 10 a.m., 2 p.m., 6 p.m., and at that time you make it 10 p.m. So it's every 4 hours. Okay, 6 a.m., 10 a.m., 2 p.m., 6 p.m., and 10 p.m. But you also note that at 10 p.m., usually we give double dose of the normal. So this patient is receiving 5 milligram every time instead 10 p.m., where he receives double dose of normal dose, that is 10 milligram. And you can also administer SOS doses of morphine. Suppose the patient has pain in between, then you can administer 5 milligram of oral morphine. So whatever be the dose the patient is taking, that should be administered as SOS dose. Suppose the patient is taking 20 milligram 4 hourly, then the SOS dose would be 20 milligram. And if you do not have injectable morphine with you, then you need to start the patient on oral morphine. So how do you do oral morphine trial? So if the patient is not taking any opioids, that is opioid naive patient, you can start the patient on 5 milligram of oral morphine 4 hourly and SOS. But if the patient is already on a weak opioids like tramadol, tapentadol, or codeine, then start with 10 milligram of morphine every 4 hourly and SOS. So now we started our patient on 5 milligram of morphine 4 hourly and SOS. And you can see he was really pain-free for the last 2 weeks. But then he needed 4 SOS dose of morphine per day. And uh, he was taking it for the last 4 days. He needs more SOS dose. So would you do anything for this patient with morphine dose? And how frequently would you give SOS dose of morphine? Or what should be the interval between 2 SOS dose of morphine? Anybody? Please unmute and speak. increase the dose to 10 milligram morphine 4 hourly. Yes. Anybody else? Okay, and this patient is taking more SOS dose. That means the previous dose or the 5 milligram 4 hourly, which we have written as 4 hourly, is not enough. That's why the patient is taking more SOS dose. That means you have to increase the dose of morphine. So, what is the indication to increase the dose of morphine? So, if the patient is taking two or more than SOS dose, PRN is same as SOS dose. So, if the patient is taking two or more than two SOS doses, then increase the dose of morphine by 30 to 50%. You can actually increase it every 24 hours, not every 2 to 3 days. So, you can increase the dose of morphine by 30 to 50% every 24 hours. So if you increase 50%, this patient is taking 5 milligram. So what is the 50% of 5 milligram? It is 2.5, isn't it? 5 into 50%. That is 2.5 milligram. So 5 plus 2.5, that will come to 7.5 milligram. So you can increase it to 7.5 milligram every 4 hourly, or you can increase because it is not very easy to break the tablet into 4 pieces, the 10 milligram tablet into 4 pieces. So you patients may complain that it's very difficult. So in that case, you can increase it up to 10 milligram every 4 hours. But please understand that if the patient is taking more than 2 SOS, increase the dose of morphine by 50%. So if the patient is taking 10 milligram uh, 4 hourly, then the 50% would be 5. 10 plus 5, 15 milligram. 15 milligram 4 hourly in that case. And how frequently would you give SOS dose of oral morphine? Suppose the patient has taken uh, first dose of oral morphine at 6 o'clock, 6 a.m. in the morning. But the patient is complaining of severe pain by 6:25. Uh, patient says, doctor, something please do. I have very severe pain. So what would you do? That's what I am asking. Would you give SOS dose of oral morphine? Anybody? Yes. Okay, they will say yes. Anybody else? Yes. We can give non-opioids. Yeah. Yes. Add other analysis. Okay. So for us to understand this, we should understand some pharmacology about the market. So this is the a plant from which we get morphine. This is known as power somniferum scientifically, or poppy plant or opium plant. And this plant is legally grown only in 3 states of India, UP, MP, and Rajasthan. Fields, but these are the poppy fields in the in this 3 states, UP, MP, and Rajasthan. And the seed-like thing is called pod. And the farmers make small cuts on the pod, and you can see the sap is coming out, which the farmers will collect and dry it in sunlight. And this will be transported to the government opium and alcohol factories. And they will make morphine powder out of it. And then it is used for making morphine tablets, capsule injection, etc. And morphine is hydrophilic. That means that is water soluble. So uh, you can actually you can powder it and mix it with water for administration for patient, and it is absorbed from the upper small intestine. Uh, and when you powder morphine, one thing is that it is very bitter. So if you give morphine tablets and ask the caregiver to powder it and give if he's unable to swallow, then make sure that it is sweetened with fruit juice or sugar. Otherwise, the patient may spit it out because it is bitter. And this is some common mistakes which some people make uh, when patient is unable to swallow. There is a practice of giving morphine sublingually, buccally, or gingival. But this route of administration is not advisable because absorption is very, very low. So, suppose if a patient told you that after sublingual administration, I got good pain relief, that means the patient has simply swallowed it, and that's why the patient has good pain relief. So, if the patient is unable to swallow, don't advise the patient to put it sublingually because absorption is very, very low. And this is what happens when we swallow the morphine tablet. It will go into the GI tract, and from the upper small intestine, it is absorbed into the blood vessels. And from the blood vessels, it will go into the portal vein, and from portal vein to liver. And in the liver, metabolism takes place, and the metabolites are liberated into the systemic circulation. So the main site where metabolism of morphine takes place is liver. And then active metabolites are liberated into the systemic circulation, and this active metabolites will give you the pain relief. So you can see 90% of morphine is converted into metabolites in the liver, and there are two major metabolites formed. Um, morphine 3 glucuronide, in short, it is M3G, or and M6G, that is morphine 6 glucuronide. These are the two major metabolites, and you can see M6G is formed in less quantity, 5 to 10% only, but this is the component or this is the metabolite that will give you the pain relief. Whereas M3G produces some um, side effects like neurotoxicity, means
Is it only for me that the screen got stuck? Or
Yes, yes, it's frozen, Sri Priya. I was also about to unmute and
so So it will take some time for the morphine to metabolize and liberated into the systemic circulation. So even though the patient will get pain relief maybe by half an hour, but the peak analgesic effect will be by about 1 hour, that is 60 minutes. So you have to wait for an hour before you administer the next dose. Okay, so when I ask you that the patient has taken the dose of morphine at 6 a.m. and when the patient is complaining of pain after 20 minutes, 20 or 25 minutes, it is better for us to wait for 1 hour because the peak analgesic action will be by 1 hour. 1 hour. Okay. So we increase the dose of this patient to 10 milligram every 4 hours. But the patient says it is very difficult for me to take it every 4 hours. And he is asking you, is there any other option? If you have like maybe if you can give it less frequently, I can take it and will have good pain relief. What would you do in such situation? Patient is not willing to take every 4 hours. Anybody? Yeah, you can see sustained release tablet. Yeah, that's an option. And about sustained release tablet, um, the duration of action of sustained release tablet is 12 hours, whereas the duration of action of immediate release morphine is 4 hours. So here the patient need to take morphine only BD or 2 times a day. So our patient was taking 10 milligram every 4 hours. That means patient is taking 60 milligram of oral morphine per day. So you can give tab morphine, sustained release 30 milligram BD. But you also need to understand that you would not or you should not give the sustained release morphine as SOS dose. The SOS dose always should be short acting morphine, that is immediate release morphine. So the previous dose which the patient was taking can be given as SOS dose. So 10 milligram immediate release can be given as the SOS dose. And we also need to understand the preparations of morphine available. So we have active solutions of syrup, then tablets and capsules, both immediate release as well as controlled release. That's the another name for sustained release morphine. Then injection morphine, that is 15 milligram per ml. And so our patient was stable on 10 milligram of morphine every 4 hours. But one day he was brought to you in the casualty with excessive drowsiness. The problem is that the patient is very drowsy for the last 2 days. And you ordered some investigations and you found out that total count has raised. His blood urea is 20 milligrams per deciliter and serum creatinine is 5 milligrams per deciliter. Are you going to do anything with morphine dosage for this patient? Or why the patient is excessively drowsy? What is the reason? Anybody?
So the metabolite also is active. If he's having renal failure, the
Yeah.
metabolite of morphine is active. So we have to stop morphine and change into tramadol, which is more renal safe and control his pain. As of now, he's drowsy. So we have to stop morphine because it's mainly excreted through kidney and the metabolism is active.
Yeah, thank you, Dr. Remadevi. So, we have to understand how morphine is excreted from the body. So, it is by glomerular filtration. So, what happens if the patient has renal failure? The morphine and its metabolites accumulate. So, whatever you are giving, that is not going out from the body because the uh, urine formed is less. So it is not washed out from the body. It gets accumulated. So once it gets accumulated, it will have many problems like extreme drowsiness and some other more problems also. So in this case, what you can do is either you can reduce the dose of morphine and then continue. Suppose the patient was taking 10 milligram 4 hourly, you can make it maybe even 5 milligram, and instead of 4 hourly, make it 8 hourly or 12 hourly or 6 hourly. But the only thing what is sure is you should not give it every 4 hours. So this is one situation morphine is administered in not every 4 hourly, but with less frequent administration, maybe 8 hourly or 12 hourly or 6 hourly. So that's what you have to do. And if you there is another option, you can also be renally safe opioids. So renally safe opioids are fentanyl and methadone. Okay. So we reduced the dose of morphine of this patient, and it was made 5 milligram every 8 hours. But then, as the patient's disease was progressing, he was unable to swallow anything, including morphine and even water. And the patient is at home. So whenever he is unable to swallow this morphine, he has very severe pain. And what would you do for a pain relief in this patient now? In fact, okay, IV, yeah, injection is an option, but this patient is at home. Yeah, subcutaneous again, it's an option. But um, through Rice tube. Okay, probably this patient is terminal, maybe going to die in another few days, maybe in a week. That's why he is unable to swallow anything, including morphine. Actually, morphine patches is not available. Morphine, we already saw that morphine is available only in syrup, tablet or capsules and injections. And it would be very difficult for you to send injection morphine to the patient. Many of the hospitals won't agree with that. Fentanyl pads, okay, liquid morphine, even that is unable to swallow. Patient is unable to swallow water. So, do we have any other option? Okay, let's see. So, what are the routes through which we can administer morphine? This is the question answered here. So, we know that the most common route is oral. So, followed by either intravenous or subcutaneous. But morphine can also be administered parenterally. Okay. Then epidural, intrathecal, etc. So, for this patient who is unable to swallow and who has only a few days to live, and the patient is at home, you can administer morphine parenterally. So, how will you administer morphine parenterally? And what is the comparison between the oral and parenteral route? So, whatever be the oral dosing you are giving to the patient, that can be given parenterally in that dosage. So, our patient is taking 5 milligram 8 hourly. You administer morphine 5 milligram 8 hourly parenterally. So, for that, you can take the immediate release morphine 5 milligram, add 2 drops of water, make it a paste, and then do a parenteral examination and rub it over the rectal mucosa. The pain relief is exactly same as that of oral route. And some people even believe that the parenteral route is more superior than oral route. Okay, so same dose, same strength, same duration of time. So now we are moving on to another patient. This is a patient, a 55-year-old woman with carcinoma of the colon, who is complaining of abdominal pain, which is continuous in nature. And she is on 10 milligram of morphine every 4 hourly, and she doesn't need any SOS dose, and she has good pain. And here again, the patient says, it is very difficult for me to take it every 4 hourly. So the doctor has asked them to replace the morphine with a 25 microgram fentanyl patch. But next day, patient comes to you and is telling you that yesterday I didn't have pain relief with that patch you have given me. So I removed the patch after 5 hours. So what would you do for this patient? Anybody? What are you going to do for this patient? Yeah, extra form is yeah, sustained release. Dr. Lifestyle says extra form. Dr. Gemma Devi says increase the dose of fentanyl. Share gains, increase the dose of fentanyl.
So the patch will take some time to reach the blood levels.
Okay, so what would you do? Okay, so when you give fentanyl patch to patients, you have to actually inform them some of the important things. So what are those important things? One is Dr. Demadeli already told. Uh, so we need to understand that when you apply fentanyl on the skin, it the drug that is fentanyl in the patch will slowly release into the subcutaneous tissue. And in the subcutaneous tissue, it forms a storage, which is known as subcutaneous tissue depot. Okay, and this for this subcutaneous tissue depot to develop, it will take about 8 to 12 hours. And once this subcutaneous tissue depot is developed, phenylalanine is then liberated into the systemic circulation. So for a patient who has applied phenylalanine patch for the first time, it will take about 8 to 12 hours to give or to get the pain relief. So till 8 to 12 hours, we should ask the patient to take the opioid which they were taking previously. So this our patient was taking morphine. So even though you have applied fentanyl patch, ask the patient to take morphine uh, 2 to 3 doses. That is 8 to 12 hours, and then only the fentanyl will take over. Our patient removed the fentanyl patch by after 5 hours. So that means there is no subcutaneous tissue depot has formed. That's why patient do not have pain. So this is one important thing which you have to inform the patient once you start patient on a fentanyl patch for the first time. So this patient actually need to continue morphine for 8 to 12 hours. But once you apply, the duration of action of fentanyl patch is for 3 days, that is 74 hours. And so you have to change the fentanyl patch every 3 days. And when you apply the patch, you should not shave the area because shaving will produce some aberration which can increase the absorption of fentanyl. And also temperature. If the patient has fever, or if the patient is taking a hot bath, or if they go near the um, cooking stove. So whenever there is heat or increased body temperature, that is going to increase the absorption. So you have to advise the patient about that. So once applied, it will liberate only constant amount of fentanyl. So if you apply 25 microgram patch, that means 25 microgram is liberated every hour. You will not be able to alter the dose of fentanyl. So it is not suitable for patients with unstable pain. Unstable pain means patient who has no pain now, but after maybe an hour, patient has very severe pain. Then after half an hour, it come down. Then maybe after 1 hour, it is again going up, then coming down. So there is frequent ups and downs in pain. That means patient's pain is unstable. So for those patients, fentanyl patch is not suitable. So these are the preparations of fentanyl available. Injections are available. Transdermal patches available. And the oral transmucosal fentanyl citrate, which is known as OTFC, which is like a lollipop. And this is suitable for incident pain. So this is very short acting. So patients can actually rub over the buccal mucosa, and the patient can get immediate pain relief. And potency wise, if you look, it is 100 times more potent than morphine. So if you calculate with 100 milligram as the potency, 60 milligram of oral morphine equivalent per day is equal to 25 microgram per hour patch. So if you want to convert a patient from an opioid to fentanyl, first you have to convert it into uh, oral morphine equivalent dose. And then from that, please remember this, this 60 milligram of oral morphine is equivalent to 25 microgram fentanyl patch. So 120 milligram of oral morphine would be equivalent to 50 microgram of fentanyl patch. So I am moving on to another patient. Mr. P, 70-year-old man, has carcinoma of the lung and is complaining of throbbing pain on right front of chest continuous, which is caused 5 by 10. He is a non-epileptic and he is also on levetiracetam 500 milligram BD. How will you manage this pain? Anybody? Patient has a pain score of 5/10. Which step of ablation and fifth ladder would you select, and what would be the medication we are going to use here? Step 2, that's right. So which medication from the second step would you use now? Yeah, mild opioid. Which one? Weak opioid. Yeah, that's correct. But what name the opioid which we are going to use? Okay, Dr. Sushil says tramadol. Yeah, I can say lot of tramadol. Yeah, that's right. But does anybody else have a comment on that? Dr. Gurinder says morphine. So actually, uh, this patient pain is 5/10. That means patient has moderate pain. So from the WHO analgesic ladder, you only need to select the second step. So you can either start with tramadol, tapentadol, or codeine. But the thing which you need to understand is tramadol can actually reduce the seizure threshold. So patients who here patient is already non-epileptic. So if you use tramadol, there is a chance that the patient may have precipitated epilepsy. So this is what you have to understand. Tramadol reduces the seizure threshold, and if possible, you have to avoid tramadol uh, for epileptic patients or for those patients who can have reduced the seizure threshold, like brain metastasis or medications. There are some other medications which can actually reduce the seizure threshold, like tricyclic antidepressants or antipsychotics. So when you combine tramadol with this, it can produce seizure. So for this patient, tramadol is not the choice, but you can actually use morphine in a reduced dose for this patient. Okay. So this is another patient uh, who is on a morphine tablet, 50 milligram every 4 hours. And it is on fairly good dose of morphine. And she's coming to you with very severe pain. You have only injection pentazocine and oral morphine tablet with it. Injection pentazocine has 14. Uh, the trade name is 14. So how are you going to manage pain in the patient? What would you give? Injection pentazocine or morphine tablet? You want to relieve this patient's pain as fast as possible. So what are you going to give for this patient? Give injection pentazocine. Okay. Yeah, pentazocine, pentazocine. Dr. Sweda says it's nothing. So
Pentazocine is having agonist antagonist properties, sir. So whatever will not be that effective.
okay. Thank you, Dr. Nadavi. So let's see the classification of opioids. Um, so opioids actually acts by combining with the opioid receptors, and there are mainly three opioid receptors: mu, kappa, and delta. Okay, so when the opioids combines with these opioid receptors, there are some neurotransmitter release occurs, and uh, that will give you the pain relief. So according to the action on receptors, action on these three receptors, we can classify opioids into three. That is agonist, antagonist, and agonist antagonist. Okay. So what is an agonist opioid? Agonist opioid means the opioid combines with opioid receptors to produce physiological action. That means the patient will have pain relief with other side effects. So that is an agonist. But an agonist antagonist means on some receptor, these opioids will act as an agonist. But on another receptor, it will act as an antagonist. So it's a mix, agonist and antagonist. And what is an antagonist? Antagonist means it will reverse the action of agonist. So antagonist acts only in presence of an agonist. Suppose if I give you antagonist, the antagonist is naloxone and naltrexone. So if I give you naloxone to you, it will not have any effect in you. But if any of you are taking morphine, fentanyl, methadone, or tramadol, it will reverse the action. That means the patient will have more pain. So agonist examples are morphine, fentanyl, methadone. All those are agonists. But agonist and agonist example are buprenorphine and pentazocine. Those are the two opioids which are commonly used. Buprenorphine and pentazocine. So please look at this graph. Uh, you can see on the left hand side, it's a graph for agonist. And on the x-axis, it is the dose of agonist you are giving. And on the y-axis, it is the pain relief. And this agonist opioid, suppose you give morphine to a patient, maybe 5 milligram, uh, and the patient's pain is 10. It's up to here. Okay. And when you administer 5 milligram, it will give some pain relief. But as you increase the dose, that will give you corresponding pain relief. And when the dose reaches here, it should give you 100% pain relief. That means there is no ceiling effect for analgesia. No ceiling effect for analgesia. So as the dose of opioid is increased, that will give you corresponding pain. But look at the agonist and agonist, like buprenorphine or pentazocine. What happens? So when you increase the dose, that will give you corresponding increase in pain relief. But it is up to a point. You can see till this point, the patient will have pain relief. But after that, even if you administer or increase the dose, the curve actually flattens. That means there is ceiling effect for analgesia. So this is the main difference between these two groups of medication. Agonist and agonist has ceiling effect for analgesia. And let's look at our patient. Suppose you want to give pentazocine for the patient. So pentazocine is an agonist at a kappa receptor, whereas it is a weak antagonist at a mu receptor. Okay. Whereas morphine is a mu agonist. So our patient is already taking morphine, and morphine is occupying the mu receptor. Suppose you are going to give pentazocine to this patient. What will happen? The pentazocine is going to replace the morphine from the mu. So now mu receptors are occupied by pentazocine. So what is the action of pentazocine on mu? It is antagonistic effect. That is, it will act opposite to pain relief. Okay. That means it will produce more pain. That's what if you give pentazocine to this patient will happen. So pentazocine is not an option for this patient. You actually can find out what happened to the patient. Did he miss did she miss the oral any dose of morphine? So if she has missed the dose, you just give the dose, or even you can increase the dose of morphine. Okay. So now we'll move on to adverse effects. Adverse effects can be divided into two types. One is side effect and the other one is toxic effects. So what are the side effects of opioids? This is very important. Can anybody tell me what are the side effects? Anybody? Side effects: tolerance, vomiting, respiratory depression. Yeah. Nothing else, sedation, and drowsiness, constipation, respiratory depression, nausea, vomiting, constipation, respiratory depression. Okay, thank you, everybody. So we will see. So, what are the side effects? Side effects means these are the adverse effects with the therapeutic process. That means you are giving opioids for the patient. The patient will have good pain relief, but with that the patient will have some adverse effects that are known as side effects. So, what are the side effects? Constipation, nausea, vomiting, sleepiness and tiredness, then itching, dry mouth, and urinary frequency. The first 3 are the common side effects, and the last 3 are rare side effects. And about constipation, it occurs in almost all patients. So the important thing is that once you prescribe opioid, you should also prescribe a laxative. It is not a laxative. You should prescribe a stimulant laxative. That is the laxative of choice for opioid-induced constipation. Stimulant laxative. The examples of stimulant laxatives are bisoprolol, sodium pycosulfate, or senna. And you might have seen the patient might be on many other laxatives like some powder-like things. This known as spagolahas or methyl cellulose. But those need to be avoided in opioid-induced constipation. You have to prescribe stimulant laxative. And another important thing is that you have to actually continue the stimulant laxative as long as the patient is on opioid. So that's another important point about constipation due to opioids. One is you have to prescribe regular stimulant laxative, and second thing is you need to continue the stimulant laxative as long as the patient is on opioid. So these two things are very important. And next thing is nausea and vomiting, and it occurs almost in 1/3 of the patient, and it's probably due to there are many mechanisms, but one of the main problem is that opioid stimulate the chemoreceptor progesterone in the brain. So uh, there are certain receptors in the chemoreceptor progesterone. So you have to block those receptors. Then we can reduce the nausea and vomiting. So dopaminergic type 2 receptors, D2 receptors are predominant in CT cell. So you have to give D2 receptor blockers. So what are D2 receptor blockers? Haloperidol and metoclopramide. These are the two medications which need to be given uh, to reduce the nausea and vomiting. But unlike constipation, you can see that nausea and vomiting is self-limiting. That means if you start a patient on opioids for the first time, even if you don't give any antiemetic, that will settle in maybe 3 to 5 days. So when you prescribe antiemetic, please make sure that it is prescribed only for 3 to 5 days. It is not needed more than that. But for constipation, continue the laxative. Okay. And next is sleepiness and tiredness. And this is again, of course, in 1/3 of the patient. And again, it is self-limiting. So maybe for the first week, the patient may be feel drowsy and tired. But after that, the body will get accustomed to that. And what are the toxic effects? We were talking about the side effects. Now it is toxic. Toxic effect means these are the adverse effects when the administered dose is higher than the required for pain relief. So you are giving more than required for pain relief. So how will it manifest? The patient can have delirium. What is delirium? It is irrelevant speech, simply. Delirium, myoclonic jerks, and extreme drowsiness. So these are the three symptoms by which you can understand that the patient can that this patient has toxic. And everybody was talking about opioids produces respiratory depression, and this is one of the fear factor for doctors when you consider using opioids. So we would look at the evidence. So you can see this is an article, a systematic review from 2003, and it says mainly the patients takes opioids orally. So and the doses are increased gradually, and they say this ensures respiratory depression is unusual. Okay, and another important thing is pain is the physiological antagonist to respiratory depression. So if the patient has pain, the patient will not have respiratory depression, especially if the patient is on oral opioids. And this systematic review continues to say that when respiratory compromise occur, then you have to look for another explanation. Like, does this patient has pneumonia, cardiomyopathy, pulmonary embolism, or are you administering a benzodiazepine along with this? So please understand that it is very, very unusual to have respiratory depression, especially with oral opiates. And I have not seen any case of respiratory depression in the last 20 years of my career in palliative care. And another thing is opioids causing addiction. And what we have to understand, there are these are the research findings. Substance abuse as a result of medical usage law. So you are using opioids for mainly for two reasons. One is to reduce the pain, and sometimes you might use it for reducing blood lessons. So they say if it is medically indicated and if the patient is using as a for medical purpose, the substance uh, this is very, very rare. And there is always a confusion between physical dependence and psychological dependence. So psychological dependence is known as addiction. Suppose many of you might be taking coffee in the morning and you have been taking it for a long time. Suppose if you don't get coffee in the morning one day, what would be the reaction, or how would your body react to it? Can somebody tell me? How would your body, how would your body react? Anybody? Irritable, headache, craving, no major illness. Okay. So it is very common to have headache, yawning, um, irritable. So does that mean that you have addiction? Do you have addiction? Do you have psychological dependence? Okay, that is psychological dependence. That is addiction. That doesn't mean that you have psychological dependence or addiction. You were unable to make the coffee because uh, you do not have coffee powder and sugar in your home. But um, if you break into the neighbor's house, which is locked, and if you take coffee powder and sugar from the neighbor's house by breaking into the neighbor's house, then that means you have addiction. But usually that does not happen. Even if you don't get coffee for one day, uh, you can adjust with that. You have been given you have been giving coffee to your body for the last so many years, and one day morning you are telling, sorry, today I'm not going to give you coffee, and your body will react to it. That is known as withdrawal reaction. That's what headache or yawning or ability means. It is not psychological dependence. But if you break into the neighbor's room, house, that means then you have psychological dependence. So that is the simple or yeah, difference between physical dependence and psychological dependence in simple terms. And please look at this definition of psychological dependence by American Academy of Pain Medicine. They say it is a neurobiological disease. So addiction is considered as a disease in genetically predisposed individuals with psychosocial and environmental factors influencing development and manifestation. That means, suppose one of you have a gene which is genetically predisposing to, which is genetically predisposing you to addiction, and if you are working in an operation theater, the environment is favorable, and one of your friend is misusing opioids, and he is coming to you and telling you that this is very good, please try. Then environmental and psychosocial factors became favorable, and you have an gene for addiction. Then there is a chance that you may get addicted to it. And this is manifested by impaired control over drug use, compulsive use, and you know that it is going to produce harm, but still you would use, and there will be failure. Uh, so this is how you need to write a prescription for opioid as per NDPS Act in India. So this is the patient X has very severe pain and you are practicing on more. You are going to write a prescription. So it should be like this. So you should write patient's name, age, and address. You should be writing the date, and the opioid name should be in capital letters, and you should write the strength of the tablet, and when all are you going to administer, and how many days you are going to give, and the number of tablets. So, and you can see the signature, name, medical council registration number, and your address. So all these are required as per NDPS Act when you're prescribing opioids. But as we are starting opioid for the first time, you would start disorder, which is a stimulant laxative, and that you need to continue to give. And we know that when a patient has started on opioid, it can produce nausea and vomiting. You have to give antiemetic for 3 to 5 days. So you have also prescribed a tab metoclopramide 10 milligram PID only for 3 days. And you are asking the patient for a review after 2 days to see how many SOF doses of morphine it is taking and is there any toxic effect. So to assess the patient, you are asking for a review after 2 days. And this is the comparative prices of opioids in India, which you need to definitely understand. So you can see when you prescribe morphine 5 milligram for our day for the patient, the epipotent dose or the total dose would be 30 milligram, and you need to use 10 milligram tablets, which would cost maybe 3 rupees 55 cents. But if you need to get the same pain relief, then you need to give 300 milligram of tramadol, which would cost between 24 to 50 rupees. For the same pain relief, you have to give a pendant patch of 12.5 micrograms, and which might cost between 250 to 400 rupees every 3 days. Whereas buprenorphine patch, that will cost about 1,920 rupees for 2 weeks. But same pain relief with methadone would cost only that is 4 rupees 50 paise. So if you have a patient who is on 5 milligram of morphine and who is having good pain relief, don't advise the patient to start on fentanyl patch, especially when they are very poor, because they will not be able to afford this 200, 300 rupees every 3 days. So this is what we have to understand. It is our responsibility to see that our patient is not suffering, and we should have good prescribing practice. And pharmacoeconomics is something which we need to be very careful. So I think I would stop with this. Thank you.
Thank you, Dr. Sunil. This is something very, very important for them. I'm glad they were all quite interactive in participating, because this is what they're going to do on a daily basis. Any questions anybody wants to ask before we go ahead with the case presentation? Or shall we do the case and come back?
I think we have hand raised.
If someone wants to unmute and ask, please do.
Yeah.
Yeah, I'm Brogan. I just want to know.
Sir, there is a loud echo from your end. Maybe you have logged in using multiple devices or someone
Yeah,
else is using. So you just have to mute.
I'm seeing a big screen. That's why I'll put it off.
He has gone away, I think. What is the maximum dose of morphine given in a? There's something in the chat. What's the
Okay,
maximum dose of morphine
so
given in a day?
that's a very important question. I think I believe that's very
Yes,
very
yes.
important. Yeah. What you have to understand is there is no maximum dose of morphine. The dose which is required for a patient is the maximum which is for that patient. So when we start a patient is on morphine for an opioid naive patient, we might start with 5 milligram per hour. And if he has good pain relief, that means that's the maximum dose. But some patients might need more than that. Some maybe I would say about 70% of patients might have good pain relief with 5 to 10 milligram of morphine every 4 hour. But maybe another 10 or 20% will have pain relief with 20 to 50 milligram of morphine per hour. And actually, I have had a patient who was on 450 milligram, 450 milligram of morphine every 4 hours. And I know one of my colleagues, they have started a patient. Actually, not started, actually, it went on increasing because the patient had pain. And they went up to 650 milligram of morphine per hour. So there is no maximum dose of morphine. Um, and
There are a
what is
couple of more questions there. What is the
the
maximum
maximum
frequency of
frequency?
SOS
Yeah,
doses?
you can.
As
So
per the need.
theoretically speaking, SS dose can be given every hour because we know that the peak analgesic effect is by 1 hour. So you can give it every 1 hour. And what is a stimulant laxative? Stimulant laxative means it is a laxative as well as it will stimulate the peristalsis. So bisacodyl, senna, or sodium bicarbonate. They are actually laxatives, but it will also increase the large volume. It is known as stimulant laxative. Okay. And this morphine tablet is easily available. Yes, in India, most of the places it is easily available. But if any of you have any problem in getting morphine, then please contact uh, Australia so that she can connect you with our facilitation team. This will they will help you to procure morphine. And what is the longest duration to give opioid safely? Can it be given indefinitely? Yeah, this is a big question, but if uh, if you look at it, suppose a patient is having cancer pain, then what happens is either the patient will be taking the curative treatment and the tumor mass gets reduced and the stimulus which actually this tumor was producing the stimulus and the tumor once it is tumor is reduced in size, then there will not be any nociceptive input. So you will be able to reduce the dose of morphine and then stop it. But the most important thing is if you have given morphine for a longer duration, or for that matter any opiates you have given longer duration, then you have to taper the dose and then only stop. Do not stop it abruptly if you have given morphine more than a month. So, or else the patient can worsen and the patient may die because of uh, increasing or advancing cancer. But in case of chronic pain, then we have to be very, very careful. because in non-cancer prone pain, if you give opioids, there's a chance for psychological dependence. It is more compared to cancer pain treatment. So in that patients, you have to be very clear. And actually, opioid is not the first choice of medication in patients with non-cancer chronic pain. So you would give other medications, adjuvants and non-pharmacological treatment. All these need to be optimized. And then if you think, okay, these are not working, you can give a trial of opioids and see whether this trial is giving. You have to actually see the benefits and the side effects of opioids. If that is not giving much advantage to the patient, immediately stop it. But if it is giving much benefit for the patient, then you need to continue. But you also need to discuss with the patient that then if you are going to take it long term, there's a chance for psychological dependence, and that the patient need to know, and ask him to take the medication that you have prescribed in the preferred manner only. So this is an agreement between you and the patient. Uh, so this is something which you need to be very careful. So this is what I have to say about the duration for which we can give opioids.
And then two more questions are there.
Yeah.
Can SOS dose be increased? Yes, depending on the need, isn't it?
So SOS dose. So when you prescribe a patient on morphine, suppose it is 10 milligram per hour, the SOS dose would be 10 milligram only. Likewise, 20 milligram per hour, SOS dose 20 milligram. No need to increase the SOS dose alone. So if you increase the dose of opioid, then SOS dose would also be increased. And what are the antagonists other than pentazocine? So the usually used for people usually use two opioids. One is pentazocine and the other one is buprenorphine. These are agonist antagonists. So that's why we discussed about pentazocine. So it is the role of buprenorphine in chronic pain management is limited, and some people use buprenorphine when the opioids like morphine is not available. Otherwise, morphine is the gold standard.
Just thing is that in that point they have to understand it's an agonist antagonist. That's why about pentazocine and buprenorphine I said they are not pure antagonists. That is something to be understood and taken clearly. That's why this is being told. They have both actions, so you have to be careful. I just wanted to add on that so that they don't think it's a pure antagonist.
Yeah. So antagonists are naloxone and naltrexone. Otherwise, it's known as antidote for opioids.
Okay, then shall we go ahead with the case presentation, Sri Priya?
Yeah.
Yes, please come to the next slide. So my patient is 68 years old male with a diagnosis of newly diagnosed advanced carcinoma of the lung with a suspected neoplastic lesion in the ileum with multiple compression fracture of the spine. The patient presented with pain in the back off and on for the last 3 months, with constipation for the last 7 days and pain abdomen for the last 5 days. In the history of patient was apparently all right 3 months back. Then he started having dull aching pain in the back, which is so mild in intensity. He's got relief spontaneously. I would like to put up the fact here before I proceed that the language poem was there, so we could not get a very accurate history. Probably he was also taking some medication from a local pharmacist. which relieves the pain. He also complained of irregular bowel habit for the last 1 week and severe pain abdomen, dull aching in nature, for which he initially attended a local hospital in Myanmar. He's not an Indian, and he was not relieved with this medication, and he presented to RIMS emergency department. On examination, his pulse rate was found to be 95 per minute, BPO 150 by 90, SpO2 of 92% in room air. Abdomen, no significant other than a mass which was felt in the labia fossa. Surprisingly, the respiratory system there was also no significant finding. He was abreast build, but with poor nutrition and mobile, was able to move around. The treatment we have given were analgesic, both NSAID and opioid, proton pump inhibitor, and proctoclytic enema. On evaluation, he was found to have mild anemia, 9.4 gram per cent. Urea and creatinine were within normal limit, but the protein and albumin were very low, 4.4 and 1.8 milligram per cent. We initially did a chest X-ray, which was a suspicious lesion in the lung field and the mediastinum. Following this, we proceed with the CCT chest and abdomen, which shows a heterogeneous speculated pulmonary mass of CL lung with multiple mediastinal nodes and multiple retroperitoneal lymph node metastasis. There was also a heterogeneously enhancing ileal wall thickening in the left iliac fossa, which was reported as neoplastic, probably neoplastic in nature. There was also loss of fat plane between the mass and the arcs of aorta and esophagus. Next, please. There are 6 members in the family, wife and 4 children. 2 are male and 2 are female. They are farmer by occupation. All are apparently healthy with a per capita income of 1 lakh per annum. This also they have converted and set the Indian office. We don't know the exact income assess. The medication we are giving is the tablet aceclofenac 100 milligram twice daily, tablet tramadol 100 milligram twice daily, tablet pantoprazole 40 milligram once daily. We are supplementing with a high protein diet, protein powder supplement, and we are planning for a chemoradiotherapy after tissue confirmation. The main concern are pain, the poor nutrition, being a just recently diagnosed that also at advanced stage, the counseling issue, and of course the language barrier. And somebody is my patient is a 68-year-old male, conscious-oriented and malnourished, presenting with back pain in the back and off and on for the last 3 months, with constipation for 7 months and severe pain abdomen for the last 5 days. And on further evaluation, found to have advanced carcinoma of the lung with an associated suspected neoplastic lesion of the ileum. The discussion points are how to overcome the language barrier, how to convey the great prognosis to the patient and family. If the pain increases or not relief, what are the options? What would be the best treatment plan? Should we proceed with the chemoradiotherapy or no treatment? And how to rehabilitate the patient? Thank you. Here, actually, the language we are communicating with the patient through one of the resident is from Mizoram, is able to communicate a little with one local from a border town of Manipur, where they are presently staying. One locality, not exactly a relative. They are able to, but even for them, it is not through the local language we are communicating. It's with Hindi or English. This is the second language for them also, the communicator, the translator.
So translation, and what is the language then the patient speaks?
Myanmar, of course, but we don't know which Myanmar is. Myanmar.
Okay.
But
that's all. So
there's
getting
local
some
dialect. Local dialect,
so
but
that's
which
some,
exactly? Yes,
these are all individual case-based things, no? So
yes,
someone
yes,
from the family or someone from local translation. These are really language. It's a blessing if you can manage. Otherwise, it is a big barrier. And finding someone common to help you in this one is what will be the best thing. Something else is in someone is. I was about to say people could chat and type in the chat and oh, legal issue.
This issue
See,
is
that
definitely
comes
there, ma'am.
next.
But
Now treating and looking after the patient is
is our
our
first priority, ma'am. Yes, ma'am.
that's our priority. We are not getting digressed with something. Sorry, not to offend the person who has typed. In keeping all like all things safe and sound, I think better move in the patient's perspective. This how to convey the grave prognosis that will be dealt with in great detail in your you will have a communication session couple of days.
Yes, ma'am.
Those
Yes.
things will be. If pain increases, coming to the pain, see in your slide, I saw somewhere pain score 7/10 also. Am I right or not?
Yes, yes, madam. That is the recent one.
Yes.
Initially, it was
So that's why. So seeing that, no, with what you've had today, so
we
is
can
morphine
definitely upgrade
available
this.
in your place?
That, madam, I think is available, but from our side, it is they are able to get it only in we have a radio oncology department. There they are able to, but this patient is admitted in the surgery department. And when we write, we can't get it readily. In simple word, we find
So
it
you
difficult to get
don't have
morphine.
a palliative care service there?
Not a formal palliative care service, but one college, medical college there, they have some unit, small unit. I think they may be.
In your hospital there, it is there?
Not in our hospital, ma'am. In another hospital in the state.
Okay. So morphine is available. So how is access to morphine there?
Maybe available, but assessment like means if I am going to write that prescription, pharmacists they don't give. Means it's
No,
difficult.
that place. No, that place where you're telling morphine is there, they will be able to give a prescription.
Yes, madam. As I said, through the I think must be the contact or they know how. But the radio oncology, radiotherapy unit, there they do prescribe. But routinely
So I
we
think
the
that in
other
that
department
case,
have bit difficult.
I
Other
will
department
ask
have
Dr.
difficulty.
Sunil to take you through that. Then what is the option there then?
Okay.
So before moving on to the question as such, the language barrier, which is of course a problem, and we had faced this problem when we were working at the hospital, where we get many patients from Maldives, and they don't know Malayalam or English or any other languages which we know. So there are many agents who also bring these patients to us. So we will take the help of those and we'll communicate with this family. And great prognosis, yeah, it's very difficult, but as the one thing is that whenever it's our it's a patient's right to know the diagnosis.
Yes.
But at the same time, we should be giving this news in less painful manner. But whatever um, things you are doing, it is going to cause sadness for the patient because you are giving some bad news. So there is some protocol which we need to follow, which as Dr. Radha told in the coming sessions. Regarding the pain, and I understand that morphine is available, but it is not
Not
given.
easily available. Yes.
It is not given if you prescribe, but it is available in the oncology department. Yeah, that can happen. So maybe I think in India, when you prescribe morphine or strong opioids, uh, you should um, you should have the experience to prescribe. So once you complete this course, you would be able to show the certificate with you that I am experienced and I have attended a course of pain and palliative care So I know how to prescribe, and probably they might allow you to get that from the pharmacy. That's one thing. But otherwise, another thing that you can do is you can also apply for recognized medical institution status. It's known as RMA status, by which you can stop all the essential narcotic drugs. That means ENDs, essential narcotic drugs. And it is very easy to get RMA status as of now. You have to just apply to the drug controller in the prescribed format, and usually they will be provided with RMA status, which you can stop the morphine fentanyl methadone. Yeah. So that's what you can do once you complete this course. But as of now, what you will be doing, maybe the dose of tramadol, which you can increase up to 400 milligram per day. That's the maximum recommended dose. That's one thing that you can do. I don't know how much tramadol is getting as of.
At present, he is getting 100 milligram twice daily, along with
100
the
milligram?
twice daily.
Okay, yeah. So there is scope of increasing the dose of tramadol.
Yes,
And
yes.
aceclofenac, okay, that you can consider. But what is the type of pain this patient is experiencing? He is having low back pain and pain on the left half.
It's probably sir, nociceptive. I'll take it as a nociceptive sir, at this point. Very interestingly, he have got fracture, which was detected more like incidentally because he doesn't have any specific complaint. Even fracture in the spine, which was a compression fracture in the L vertebra, lumbar vertebra, and D12. But if that also start having some pain with the neurological component afterwards, maybe it could become more difficult to manage. As of now, it doesn't have.
And actually, when you presented by viewing the first few slides, I thought that this patient has spinal cord compression because he has no pain, he has constipation.
He constipation, and maybe so he's having some neuropathic component also, right, sir? But it's just not very obvious severe pain, not very obvious severe pain. Except more severe pain is of the pain. And, there are multiple, very surprisingly, multiple retropathies. Some of them reaching up to size of 3 into 2 centimeter, which is actually very large peripheral enhancement and necrotic. And we can even feel. Yes, sir.
There is a lesion in the left iliac fossa. And
yes, sir. There is another, maybe some component of colic component may also be there. Though we don't find in the X-ray in the CT, we don't find any evidence of obstruction SS now. But he was saying some constipation also, and in the ileum there is thickened, which may be neoplastic also. It will be very surprising. It could be a second one or a mess, which is rare.
So in addition to the lesion in the left iliac fossa, you also talked about
lungs, sir, which was very surprising. Which is more
in the and usually this lesions still have peritumor edema, and once you reduce the peritumor edema and inflammation, then the patient can have a better control. And I believe maybe
yes, I think that
steroids might.
Steroids, yes, we are also thinking about that, sir. Maybe steroid might have a little.
Dexamethasone, maybe in the range of 8 milligram once daily in the morning.
Yes, sir.
And I think you need not combine it with aceclofenac.
Yes.
You can take out aceclofenac for the time being and dexamethasone.
Add the steroid, yeah. Yes, sir. That could be a better.
Along with maybe paracetamol.
Yes.
But paracetamol, the optimum dose, maybe 12 milligram per kilogram body weight every 6 hours.
Yes.
Up to 4 grams is there.
Yes.
And I hope this patient is getting maybe this quartile, and give him good regular bowel movement. Even though if you don't suspect complete in the state of, because uh, this patient is fast in motion, but
Is installed now. So there is no SS evidence of an obstruction now, but the possibility of it developing is definitely there with that.
and I think the treatment plan, I'm not sure, but I think once you have a better picture about this
Yes, yes.
patient,
Mhm.
whether it is lung, primary lung with bone metastasis, and or if it is a second primary GID, I'm not sure.
Yes,
So
yes.
you have to
Evolving
consider,
that
yeah. So you have to consider his performance status and all the other aspects. Even you have to talk to the patient about uh, what you are thinking, and you can also discuss it with oncology department what they would do for this patient and be a mediator between the patient and oncology department. And
yes.
along with discussion with the patient, you have to come to a definite plan of action, whether to go with chemotherapy or radiotherapy, whether it's going to give any good for the patient. So if
Yes,
chemotherapy or
definitely.
going to be good for the patient, then you will do.
Good for
Otherwise,
the, not just for the sake of treatment. Yes.
yeah. And rehabilitation is another important aspect of palliative care, and maybe this patient may not be able to do anything in the coming days. So it is important for us to support the family through this difficult time. And
Yes, yes.
as we are from another country, I don't
Yes.
know how to take
Yes,
this forward.
so that that problem is there. How we can
Otherwise,
help in the
Myanmar, I'm not sure how much palliative care is there. Any other NGOs
I
are
think,
there.
sir, the healthcare system is very poor from whatever, at least at the border area, from whatever little we are able to communicate. It seems to be very poor.
That's what, like, thing is that, as Dr. Snell said, adding paracetamol, making sure gut protection, and adding some adjuvant might help in this patient. And then an MDT, multidisciplinary team management, is what will be very helpful, because in diagnosis and then what is the treatment option, everything, then discuss with the patient how long they can stay here. So many factors to
Factors are there,
be
yes, ma'am.
taken.
Yes, ma'am.
Then comes rehabilitation, both patient, carer, family, and
Yes,
total care.
yes, ma'am.
Nice, nice that many are aware, like, what are the, see, this border area, these are all the things additional you can face.
Yes, yes, ma'am.
Good, 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 good. Anything else is there in the chat? Just let me have a look. Google Translator, each one, they're giving some options for you. One last thing, as patient having low saturation, can we start morphine safely? What was
At
the
the present
saturation?
time, at the present time is 95, ma'am. It's normal at this time. Yes, but it may come down because the possibility is always there with the finding with.
And you said there is some issue with the lung also. So everything on a day-to-day basis, clinical examination and everything done regularly is what will help in the management. See, we don't just treat numbers, we treat patients. That is what you have to see always. And that doesn't go anywhere. Something to be remembered all the time. Anything else?
If this patient has breathlessness and tachypnea, I think I would definitely start this patient on morphine, which will decrease the rate rate, and it can actually improve the saturation. Not it is going to reduce the saturation.
Yes, we'll try to find out the availability, so how it can be done, sir, and contact with others.
Because once pain is relieved, so much benefit the patient will get,
Will
isn't
have,
it?
yeah,
So
yes, ma'am.
anxiety, pain relief, everything will give, that's what, like
Quality of life also
assessing his
improves.
pain
Yes,
and managing his pain very well will help in a long way.
yes.
Jansi, you can get in touch with our facilitation team who can actually
Correct.
help you to find out north in your area. Simply, please
Okay, sir.
Ah, we can
Yes.
link the regional coordinator to for you, and then you can get in touch
Yes, ma'am.
and
That
find.
would be
See,
nice.
that
That
is
would be
how,
nice.
no, that's why we have our regional coordinators to help,
Yes.
and
That
so
would be
that
helpful, ma'am.
ultimately the patient gets the benefit.
Yes, ma'am.
Hmm. So, Sripriya, you please give him the contacts, and so that he can move forward from there. And you can
Sure.
inform the regional coordinator also about Dr. Gyan will get in touch and things like that.
Sure, we'll do that.
Then over to you, Sripriya. I think there were no more. I just checked the chat. 1 second. Prognosis can be told to the patient and family by meeting them separately. Yes. So as I said, no, these, like, you will have a couple of this sessions on communications, how to do, what to do, where to do, when to do. Everything will be answered. All questions, all question phrases will be dealt with in that.
So thank you, Dr. Sunil, for joining us. I know you always have very busy days. I haven't seen you personally for the last few months. And still you found out time to interact with us, and you took out time to patiently answer all the queries. Thank you so much for that. And thank you all the participants for making the session interactive. This is what we basically expect in all the sessions, to be interactive, to put out questions so that everyone in the team learns more. And so with the promise that we will meet again in the next session with another interesting topic. This is Sripriya, along with Dr. Sunil Kumar, Dr. Radha Venkatesan, and Mr. Anup, signing off from the Tips Eco. See you in the next session. Till then, everyone, take care. Bye-bye.
Thank you to one and all. Thank you, Dr. Sunil, too. Bye.